before. Or there's like, nobody's elucidated how we get from point A to point Y, knowing that these things are things that we can change along the way. So that's what I try to do with a lot of the work I do in my lab. And then part of how I make sure I do that is I have one of the largest minority populations in the area that I am, Hispanic Latino individuals. So I make sure I have a bilingual, bicultural member on my research team. I don't live with type 1, so I make sure one of my team members lives with type 1. And then I have the immigrant and low income experience. And then we work on I do my best. I tell them I'm not scary. You should just tell me the truth. But I work my best to make it non-hierarchical so that everybody can contribute. So study questions are most relevant to people living with diabetes and the communities, and that they fill the hole that needs to be filled. That's that's a nice image. I imagine the studies that we design in our lab to be the stepping stones so that each person can kind of like take that step as they go up and really get the care.
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
So I'm here with this renowned, amazing doctor. So I'll allow you to introduce yourself before I mess up with the name. Okay, Dr. Addala, please, if you may introduce yourself.
Thank you so much for having me on. So I'm Ananta Addala. I'm one of the peds endocrinologists at Stanford, and I'm also a physician scientist. So that means I've had the opportunity, and sometimes what feels like luxury, but certainly passion, to spend the majority of my professional life really digging into things that I care most about, which is how we can really make sure that access and choice are a reality for everyone, and that's through breaking down structural barriers. And that's what my work is focused on for the most part.
Thank you so much. I think already that takes me to the first question, focusing on disparities, socioeconomic status, everything about it, like where your work focuses on. And I know that even your research papers, everything that you've researched centers more on that. It has shown the socioeconomic disparities in pediatric type 1 diabetes and how it is worsening, especially in the US. So of course, yes, it's in high income countries, but we know of these things. So like maybe if you could share with us briefly, what underlying consistent behavioral factors do you believe are most overlooked in this conversation?
Yeah. That's great, because that's essentially what I spend all my time doing, so it's something I could talk about at length. But I focus a lot of my effort on what the systemic challenges are, because anything that's behavioral or at the individual level, certainly personal choice is choice. And I just want to make sure that choice genuinely reflects what that person has the ability to thrive with and think about. So that's why I focus my efforts on the system level. At last year's ISPAD, actually, I used an analogy because although I'm now in a high-income country, I was in a sort of low-resource country to begin with, and particularly in a lower section of it, which was in a very small village in India. And so at last year's ISPAD, when I was talking about high-income countries, and especially coming from a high-resource country to ISPAD, it's a real reality check, right? And then when you look within the US, for example, all children have access to insulin, which is not the case for all adults. So when given the opportunity, we can always say, well, someone has it less resource than we do, so at least we're not that. And what that does is that propagates inaction. So one of the examples I used at last year's ISPAD was one of my neighbors, 10 minutes from where I lived in my village in India, had 2 small huts that they lived in. There was some kind of somewhat dirty running water in the background, and the front hut was for cooking, and the back hut was for the 6 of them to sleep in. That's a clearly low resource setting. And then I used one of my current neighbors, and for anyone in the audience who's been to the Bay Area, there is this place called the Winchester Mystery House, and it's a sprawling mansion. It's massive. It takes up a full city block in San Jose, which is one of the big cities. But the way that it's constructed and all of the wealth this woman had is that there would be doors that open nowhere. There are stairways that go into a ceiling. There's rooms that narrow as you go along. And I think that was a really good analogy of the type of struggle that the diabetes community worldwide is facing. In some cases, you're under-resourced. In some cases, you have plenty of resources, but the system has been designed in a way where access is just as much of a false promise as it is in the first. And so that's why I think and that's why I say if you say, oh, well, at least we have this or that, we still don't have the highest level of care for all children, and they all deserve it. And so whatever is keeping us from getting there is what our priorities, no matter where you work, where you live, where you thrive. I feel like that should be our priorities. There's always an opportunity.
Thank you so much for that, even for using that analogy. Maybe I could try to imagine when you were presenting, maybe you had sort of like a picture.
I did, yeah.
So that people could see what you're talking about.
Yeah.
And people can relate more. They'll try to pay attention. What is she talking about? So thank you so much for breaking it down like that. That is just amazing and interesting. And thank you for focusing even on those disparities in socioeconomic issues where people living with diabetes are facing, because you could just choose anything. You chose to be on your own to do, even if you live in that amazing country, working one of the best universities in the world, but you chose to focus on that. So thank you for remembering your roots, where you came from, and focusing on that. Our next question is probably to talk about the bias in systems. So yes, we know there's so much. It's false promises, like you say. You have documented some of these things, like against the patients with public insurance.
Yeah.
Tell us, like, how do we begin to change these implicit bias at a structural and training levels within a healthcare system? Because you work in the health system myself.
Yeah, I think implicit bias is so hard because first you have to accept that it exists, right? I think that's sometimes a rate limiting step. I was a biochemist, so I talk about action potential. But I think, and because it's hard to measure, it's hard to see, and because it's implicit, it drives decision making in a way that people don't even realize, the silent player. So that's why one of the first things I tried to do was just see, could we measure something that's very difficult to measure? So what's really encouraging about the diabetes community at large, especially the healthcare professional side, is when there's data, there tends to be a response, an acceptance, a cultural shift. So once we were able to document that a vast majority of people who provide care for individuals who live with diabetes have some type of implicit bias, then we started to try to understand, why does that occur? And I'll tell you, because it's often a silent and an unrecognized player in things, one of the best ways to give a solution to implicit bias is just to start standardizing treatment. Because implicit bias also, people think it comes from an ill intention, and almost never does, because most people who are pediatric endocrinologists, they care, and they care deeply, right?
Right.
We could have been anything else, and that's what we chose, and it's because we love to work with the families, we love to see the resilience, and so the intention is never ill, but often the end result is. So many times, and this came up in the session we were just sharing about open source AID and whether a family is ready for it. And I think that perhaps that question and answer shouldn't sit with the clinician. That question and answer should really sit with the family or the individual living with diabetes. And so if they don't feel ready for something, they're not going to use it. But also, what can I do as a healthcare provider to make sure that I'm allowing them as many opportunities and resources, coming back to resources, as somebody who shows up in my clinic and says, I'm ready for open source AID. I heard about it at XYZ while I spent an hour researching after my child was diagnosed, right? So I think the question is, how can we level the resources? And the way that we do that is by saying, here are the multiple systems that are available, all of them. And then listening to what the family says and then meeting them, but making sure that we don't gatekeep. And that's what I call that study. I called it the gatekeeper study, because some gates, they always stay open. Some gates automatically spring shut. You open the door and it'll just shut back again.
Shut back, yeah.
And so how can we be a sort of
Create
open
like a
purveyor?
bridge.
Exactly.
Yeah.
But I found that approaching anyone who's eligible for a study, anyone who's newly diagnosed, anyone who's had long-standing diabetes, and putting my assumptions about what I think they can do aside, my perceptions, my knowing from all my years of medical education, and just having a conversation with the human sitting next to me tends to go pretty far. And then often they'll be a lot more ready. And this is not just my experience, it's been the general experiences. Oh, yeah, that sounds really reasonable. Or I'm worried about X, Y, and Z. We'll troubleshoot it. So I think my suggestion to everyone has been approach. And so if you're someone living with diabetes and you haven't been approached, you do the approaching.
Yeah.
I empower you to do that because it's your health.
Wow, thank you so much for that, for being considerate, like trying to look at both sides, because it's not like you're just dictating to say, you need to use this. You need to create an environment where you feel like they are ready to use it. Because if they're not, they're just listening to you. You never know what they'll do home, right? Because 99% of the times they are on their own. You only get to see them when they come to clinic.
Exactly.
And maybe they could not be like a way for you to follow up to see like, are they really coming back? What is happening? Maybe you assume they moved to another state. So that would be different. So thank you so much for all that you do, your passion, especially working with the family. Because if you decide to work with peds, mostly you're speaking with their parents. The kids, I don't know if they get to respond to questions, not so much. Some of them, they'll just be quiet. They'll just listen when you're speaking with their parents. So thank you for all that you do. Picking up some of these accesses. I wanted to know when children lose access to diabetes technology due to this insurance interruption that happens. I know that happens a lot. Maybe they were being covered because your parents were working there. What would you say? It's more than a policy issue, the way I say it. I feel like it's also a healthy and an equity crisis, the way you see it yourself. How can we make to see that there could be some bit of continuity, making sure that this access is protected as a right rather than a privilege for people to know diabetes?
Yeah, I mean, I could not agree more with that sentiment, right? You said the most important thing, which is that access is a right.
Yeah.
Where you live, what you make, what you speak, how you look, shouldn't determine whether you get to have the standard of care or not. And I think that because of the reality of what it sometimes means to deliver healthcare, which is in the case of the United States and many places, there's not a government paying the insurance or there's only so many dollars, so they have so much money that they start rationing the way that care is delivered. And in that rationing process, that's where it changes from a right to a privilege, and from something that is optional, something that moves into, oh, well, if you prove that you will wear the sensor, that you will check said number of times in a day, then you've earned the right to own a CGM. When really you earn that right the moment you get diagnosed and the moment you choose that that's something you want in your life. And so right now our health policies don't reflect that. And then what ends up happening, if for any kind of clinicians or future clinicians that are listening, sometimes things that make us angry in clinic can drive really important study questions. And for people living with diabetes who are listening, things that make you angry can really drive, really important questions. And so I remember noticing that my families who were publicly insured kept having these interruptions. And I said, diabetes is hard enough to manage. Everybody knows that. And then if it's changing, one day you're checking your sugar through a finger stick because you don't have coverage, and the next day you're getting a CGM, and then you lose coverage and you gain coverage, surely that's disruptive. And that's exactly what it showed, right? It showed that glucose is worsened when you have interruptions. And so now it's not even about the right to choose or those, it's about doing harm. And one of the first things almost all clinicians have an oath to do, first do no harm. And so the moment you start doing harm by the way that we do our policies, then it's on the responsibility of the clinicians, of the care teams to say, we have to do something different. So in our case, we advocated locally. That's sort of the thing that always confused me, right? As humans, we mean to do well, and then we keep designing policies that don't quite support that. And so if we can start breaking some of those down, then hopefully we can lay the pathway, lay the groundwork and the evidence base to say, yeah, no, making access less bureaucratic, less paperwork, less cumbersome means that people are more likely to uptake, and then the population as a whole does better.
Wow, that's an intelligent response. Thank you so much for that. It's enlightening, and I know that it's going to inform even for people that are going to watch this to reflect on the way they do things and how they should have an approach, because everything that we do, it will almost everything around. Everybody needs to take a part to contribute, to make an impact, to change. The end goal is just for people to achieve like a good quality life with their diabetes. So there needs to be continuity, because you cannot say, I'm using a CGM this week, next week I don't know if I'll have access to it. Because if we are to even track the trends, sometimes if it's missing, something is not there, it will be unclear, then I think we'd have lost it in terms of equity balance. There's no equity whatsoever. Yeah. So thank you.
And the experiences that you've had, chances are you're not the only one, right? And so then to know that as you troubleshoot something, sure, it's for your own benefit, but it ends up being, you're almost never alone in any challenging experience or any positive experience you've had. And so then coming together, because then it ends up solving it for other people too, or empowering other people too, which is a lot of what the work you do on your podcasts are.
Wow, thank you so much, Dr. Addala. This is amazing. Yourself, you are a clinician, you're also a scientist, you do research. You said you own a lab, right? How do you balance these human stories behind the statistics with the objective of the needed of research, especially when dealing with vulnerable youth and families?
Your question is a great one, and I think maybe I actually have the narratives inform the research. So even this example I just gave you, I would sit in clinic and my kids with public insurance don't have access that's consistent. My kids with private insurance in the United States did. And then there was the study question. I would observe and notice that people would say, oh, this is a really high information seeking family. I just want to give them all the information now. Versus this family already has so much going on. Let's be really thoughtful about what we load them with. That was the source of the clinician implicit bias. I have families telling me that, I don't know if I can call it discrimination, but people speak to me differently once they realize that I have an accent or they look at me. So each time what I try to do is, and this is why I value every patient interaction I have and every person with diabetes interaction that I have, and just the ability to just sit and learn from our collective experience as humans, because it usually tells me what the next study question should be, because there's usually a dearth of data. Nobody's looked at it before, or there's like nobody's elucidated how we get from point A to point Y, knowing that these things are things that we can change along the way. So that's what I try to do with a lot of the work I do in my lab. And then part of how I make sure I do that is I have one of the largest minority populations in the area that I am, Hispanic Latino individuals. So I make sure I have a bilingual, bicultural member on my research team. I don't live with type 1, so I make sure one of my team members lives with type 1. And then I have the immigrant and low income experience. And then we work on I do my best. I tell them I'm not scary. You should just tell me the truth. But I work my best to make it non-hierarchical so that everybody can contribute. So study questions are most relevant to people living with diabetes and the communities, and that they fill the hole that needs to be filled. That's a nice image. I imagine the studies that we design in our lab to be the stepping stones so that each person can kind of like take that step as they go up and really get the care that they want. And that's what I love our lab to do.
Thank you. This is beautiful. I always love to hear healthcare professionals. We hope to see where we could work together, involve people living with diabetes in the things that you're doing to make sure the decisions are really informed. Yes, you know so much, you've experienced a lot, you see people in clinic, but also involving them in your team. Wow, that's a plus. Thank you for that. We don't have that everywhere. So those that are watching, if they could also learn something, if they could get inspired, because it's always great to be informed. Whatever that is you're going to research is informed from what you learn in the clinic. That is fantastic. Thank you so much for that. And I think maybe the last question that I have for you, the role of advocacy in academia. For example, we have received both research and advocacy awards at Stanford. Yes, I saw the the right number. How do you see advocacy fitting within responsibilities of scientists and clinicians? And is it possible to separate them?
It is clearly possible to separate them, but the question is, there's always that question, just because we can, should we? And I think that if you ask anyone who's in the medical world or anyone who's a scientist, why do you do what you do? The answer is almost always going to fall in the line of to make the world a better place, to help somebody living with diabetes, to move the field forward. It's never so I can be on 12 new publications or get this awarded, right? So if you look, most people's motivation is for betterment. In order to truly better humanity or better the community within a disease process, inherent to that is advocacy. Because otherwise you would just do the science and say, oh, sweet, this was amazing science, and then leave it at that and never have the data do the work. So the data doing the work is advocacy for me. And so I think that's why I try to ask policy relevant questions. I try to ask things that would inform the clinic. So I think what I love about advocacy, because I remember learning about advocacy in the United States, they at least talk about it like you go to a government office and you stand with a board and say like CGM for all, and you hold a sign up. And that is advocacy. But also advocacy is designing a study to say those paperwork that you're doing worsens glucoses. Advocacy is saying, I live with diabetes, and let me tell you how many decisions I make day in and day out.
Advocacy differs depending on the context.
Anyone can be an advocate. You're an advocate sitting here. Every single person who's chosen to show up at ISPAD or any learning environment is an advocate for them So I think there's an artificial separation of advocacy from the work we do, but I think the natural tendency is actually for advocacy and any professional or personal passions to come together, because our goal for people broadly to live the best lives that they can. I'm not sure if that directly answers your question.
Well, thank you so much. That is brilliant. I cannot thank you enough, even for bringing us to attention that advocacy is not always about holding a placard, going to government offices, waiting for government days to go to Washington, D.C. to say, yeah, Congress people, I think this is how we need to do it. Talking about your condition or drafting your paper so that it could inform, because people are going to use that as evidence to say, this is good. So that's advocacy for you, because you are doing your work, right? So thank you so much for that. Lastly, I think on the forward look, I would like to think that you're an optimistic person, yes, hopeful in the future that things are going to be well, things are going to be well. Yes, it's another thing. For immunologists, yes, they'll be like, I want to find a cure. But maybe for you, with the things that you're doing, trying to level up things on equity issues, to address those disparities in socioeconomic status for people. So if you could reimagine the pediatric diabetes care in the next decade, one that truly addresses these disparities and centers families, what would it look like, and what do we need to do to change that?
That's a big question. And then you ended with one thing. I don't know that I have one thing.
Okay, so say
but no, I'm teasing. But I think, let me actually zoom a little bit out. Sometimes when I give talks, I talk about what's a disparity. A disparity, the way I define it, is something that works well, that isn't properly it doesn't have access. That's
we know that.
And the
it works.
overlap where those two things meet, right? Things that work that everyone doesn't have access to.
We know that they work, but not everybody has access to it.
So what does that mean? You said look ahead to the next 10 years. That's going to be even far more innovative technologies. It is absolutely going to be therapeutics. I have zero doubt about that, right? Because that world is already here. Yeah. I'll tell you what we've learned from the diabetes technology world is that if we don't bring everyone together as innovations occur, we leave people behind, and then we don't often work towards catching them up. Whether that's within a country, whether that's within a city, whether that's between countries. So what I would love to do is make sure that every step of the diabetes innovations that are going to continue actively prioritize representing all people living with diabetes. That is at the level of the clinical trials, that's at the level of health policy, so that when it comes time to implement, we aren't designing systems just for one group of people. We're designing ones that work in all climates, in all languages, on all people. And knowing where the future is going, we can see it already, and making sure that it's designed intentionally, thoughtfully. And part of that means that we include everybody in the conversation. We don't say, oh, we'll start here because that's the easiest, and then we'll apply to everybody else. We'll start with as representative as we can.
Thank you so much, Dr. Addala. I don't know what to say. I don't know how to thank you enough on behalf of the global community that is going to watch this. It's because it's not just for people with diabetes, but for everyone, researchers, people living with diabetes, and anyone, even family members. So thank you so much for clarifying it, breaking it down to make sure that it becomes plain language. Because every time I read these research papers, I feel like, I think researchers should ask themselves, what does this mean to people living with diabetes? It should be understood by even a layman in the street, because not everybody is educated like you are. Sometimes not everybody understands these graphs, everything that you're talking about. So it needs to inform and improve the system or improve the way people live. Thank you so much. If you want to say any last words.
No, you genuinely don't have to thank me as much as you did, because first off, it's a privilege and honor to do the work that I do. So I feel like I'm getting away with something. That's a statement. And how could I be so lucky to do this work? But also, I am part of one piece of many things. And so I appreciate that you take time to sit with people to get exactly this, get at the dissemination, because if people know the data that exists out there and know that it's reflecting their lived experience, they can feel more empowered to say, no, I do want us to talk about that technology, or to help me understand why you don't think that would be the best fit for me, and just empowering people. So thank you for making sure that you get us on here, get us talking, and that you get the word out so that the innovations aren't so exclusive.
I'm humbled, and you for being humble, so that means, usually nobody wants to take credit for anything, even if you feel like they deserve to be thanked. But thank you so much. That is amazing. Thank you. This was great, and I hope that this will inform people, educate people, and motivate people as it should. So that is the reason why we do it anyway. So thank you so much. Great.